or audio-visual?
Audio and visual.
Oh, so they are seeing me.
Recording the slides, we're webcasting the slides.
Okay.
So
But not me. That's correct.
But they can't see you. They
Excellent.
They can
That's all I.
see your PowerPoint and they can hear you.
That's great.
They
That's all.
can't see you in your red tuxedo.
Excellent. And this thing is not working, or is it?
We haven't tried that.
Okay. Yeah. That's okay. All right. Why you just start so you don't have to of my next day to go and see. So excuse my little bit of a cold. So, but I hope that you can hear me and feel free to stop me at any time. My name is Ehab Saad. I am the medical director of the kidney program and pancreas transplant at the Froedtert Medical College. I'm actually one of the MPs. I actually started from way at the bottom of the ladder here in 2005 and went up to the ladder till I became the medical director. I also have under my wings the training program for the junior folks to become the next generation as a kidney transplant physicians. I have been here for 11 years. And actually, I am very excited because I identify few faces here in this room. So that's very good to see you outside the hospital setting doing good. All right. When I was asked to give a talk, most of the time it would be left up to me to pick the talk. So I can, you know, find a little bit of an ease of working around stuff that I know or I don't know. But this time I was asked to give a talk about a title, the 10 things that I wish my patients would ask me about in their follow-up visits. So it was no choice was left for me. So that was the first challenge for me. And the second challenge is that how can I make it very simple? I have to admit, when you are, you know, you're dealing with medical students, you are dealing with medical terms every day and night. And now you come to the layperson's presentation. That can be a little bit challenging for me. So please forgive me. The slides may be a little bit complicated, but it's not meant to just go through the details, but just to give you the bigger picture. And I tried my best to simplify it, but still get the message across. Make sure that this thing is working. So while the slides are not moving. Okay, I need help with the slides.
So do I.
Okay, great.
Should I try and get,
It was working before. Okay. Good. So I have to disclose if I have any financial interest, or I'm going to sell you something, and there is nothing, okay? So under disclosure rules, I am required to tell you that I have no disclosure related to this presentation. It's really coming out of my good heart. All right, let's start. I love this cartoon. Transplantation is like a marriage. It's a blessing for many, curse for some, but it's a risk for all. So you can see no rings. So I don't want those who are married to think that I have anything bad against marriage, but it's really that is the case.
You can go forward back.
All right, thank you. So I asked myself, how I'm going to come up with a presentation about the topic that was given to me, and frankly, I haven't discussed it before. And I like this one. If I cannot explain it simply, that means that I do not understand it enough. So I am putting myself up to a challenge. By the end of this presentation, if you feel that you haven't understood me enough, then I haven't been able to explain it enough to you, or I don't know it enough. And that would be a problem for the medical director of the program. So please. So I'm trying to come up with very simple 10 points. And Larry came to my mind when I said, okay, here we go. The top 10 list. I don't have the cards and I don't have the music, but I promise I have the rest. Okay, I'll start. Number 10. Kidney transplantation. It's really a gift that I wish my patients ask me beyond the scene. How much did it take to come to this point? How much did it cost? And how much sacrifice has been done there? And you will be amazed by the numbers. And I'm a kidney transplant physician, so sometimes I will emphasize the kidney part, but most of the time I try to be in a general term that can apply to any organ. So for this one, any idea, just for a kidney transplant, if there is any kidney transplant person here, can give me a guess, how much does it cost for 1 year from the time you get a transplant to the end of the first year for a kidney transplant, by any guess? Yes, sir.
50,000.
50,000. Higher. Oh, I see no finger at higher. Give me numbers. Just for the kidney. 200. Okay. Here is a number. 334,000 for the first year. Do you know that before going to the operating room, you already spent 84,000 before we put the kidney in you, just by going and getting the kidney from the other place and bringing it to the hospital? First month, 1 month before transplantation, we spent 23,000. In the hospital, on average, you stay 5 days. $120,000 dollars, $120,000. First year, 334,000. What's interesting, this firm actually is located in Milwaukee. And every year they come up with this very trustful analysis about the cost of transplantation. And they talk about any and every organ. The most expensive is the heart and lung, $2.5 million for the first year. Kidney, pancreas, 560,000. And the list go on. If anybody is interested, I can send you the reference. But that is how much. And why I'm bringing that issue up? Because from time to time, we feel, you know what, I'm going to get transplant, I'm not going to take my medicine, or we get this kidney down the drain. That's how much from a money stand-wise, and that's for the first year. But you know what? If that is so expensive, why we are pushing for transplant? You know what? From a health standpoint, we talk about why transplant is better, but also even from a money talks. Look at how much dialysis costs us. Hemodialysis cost without admission to the hospital is about $125,000 a year. And the number is going up. Peritoneal dialysis, 85,000, and the number is going up. But if we do a kidney transplant and we get it right, it's about $35,000. You cannot beat that. So why you are telling me 334,000? That is just for the first year. The costs keep going down to break even at 2.5 years. But look at this. So that's why, even from a financial standpoint, there are people that just talk numbers, but that's how it is. Transplantation on the long term is cheaper, but in the very beginning is very expensive. So, you know what? We know that people have to wait for a transplant. Why every time I come to you, you keep pushing me to find a living donor? Why I just stay on dialysis? Look at it, it's very amazing that this is the data from Medicare. So it talks about patients above the age of 65. 65, 70, 79, above age of 80. The first two columns talk about patients on dialysis comparing the death in certain group of patients. Patients that are on dialysis are at higher risk of dying than those that are getting the transplant, those with cancer, those with heart problems or vascular disease, and those with diabetes. Something you cannot believe it. A patient that is on dialysis at a higher risk of dying than the patient that is having cancer. When you took everybody together, isn't that shocking? That's why we say, you know what? Let us see whether we can get a living donor. Let us see whether we can get off dialysis. Yes, dialysis may be painful forever, but if you have a chance to get a transplant, please do. You are at a worse risk of dying because you have been on dialysis than having a cancer, diabetes, high blood pressure, stroke, or heart failure. Very shocking, no matter what is the age group. Not only that, okay, I did my best, I will be on dialysis, I will wait for an organ. Wish somebody can say to me, Doc, I wish that somebody would have pushed me to get off dialysis as soon as I can, if I can find a living donor. Why? Because the longer you stay on dialysis, the more likelihood you are going to suffer on dialysis or die on dialysis. You can see that the risk is going higher and higher the more we stay on dialysis. You see the number, the first 6 months in comparison to 4 years. Higher and higher. 101.6 in comparison to the 0 there. So the longer we stay on dialysis, the more likely we are dying. That is why I wish my patient would have asked me why you are pushing me for a living donation, or why would you keep pushing me to find a donor or get on the transplant list. We don't know what does that gift mean, but look at the numbers. This is the comparison of the patient that gets a living donor, that is the yellow, in comparison to the one that gets deceased donor, in comparison to the one that's staying on dialysis. This is the number of years you are going to gain. The younger the person, the more likelihood they will benefit from a transplant. You see the one that is in the less than age of 40, you will gain 45 years by getting transplanted in comparison to dying within 15 years on dialysis. And look at the living donation, huge difference in comparison to a deceased donor. Yet transplant always work better than being on dialysis. Important for two things. One, you have a gift. Please do everything that you can to keep that gift. Dialysis is not the answer. Dialysis is just the bridge to get to the transplantation. Yes, sir.
Do you have a cutoff age for kidney transplant? I know heart is 70 years old.
Yeah. So that is a very good question. There is no absolute cut age. I can tell you that the most recent case that we have done within the last 3 months was a 79 years old lady, okay? And the oldest we have done at the medical college in Froedtert hospital, guess how old is that person was? Any idea? 84. She was just checking. So age by itself is not an absolute contraindication. But I have to also admit, when the patient is at the age of 70 and above, we start looking at them case by case. So, for number 10, I wish that the patient would have asked me how much money did it cost to be a transplant patient. Tell me in numbers what was my life expectancy if I was staying on dialysis. And I wish you hammer me to keep that organ in place, take my medicine, because dialysis is not fun. Right? Number 9. Vaccines. Yes or no? That's another very common question. I will talk as well in general terms to everybody about vaccination. Would you go for vaccination? You don't go for vaccination after transplantation. Any idea? Yes.
If it's a live virus.
Love you. That is it. Yes, we'll do it at the end, I promise. You owe me a hug.
We'll get that later.
Sure enough. That is the message. If nothing else to get out of this, no live vaccine. That's number 1. Number 2, vaccines are important. Please make sure you are up to date on your vaccination every year. So, I have a wonderful patient sitting here. She said that she's going to not to give her live vaccine. What does that mean for that poor soul sitting here? And for me, any idea? So one of the vaccines is known as yellow fever, okay? And I am originally from Africa. There are certain countries in Africa that it is a must to have a yellow fever vaccine before you go to those countries. And if you don't, you cannot enter the country. And the yellow fever is a live vaccine. I have one dialysis patient that she couldn't go and visit her country because she got a transplant and it was a mandate for her to get the yellow fever vaccine. What's the heartbreaking news for her that she cannot go and visit her country. But that is the bottom line. That's how far that person was willing to sacrifice because of the precious gift that she had. So live vaccine is a contraindication, but also make sure you are up to date on your other vaccines. So what are the other vaccines that you are going to ask your doctor, hey, let's have a talk. Should I be up to date on those or not? What? Yes, sir.
They insist on a flu vaccine.
Excellent. Every year, flu vaccine. Yes.
Pneumonia.
Very good. And there are 2 types of pneumonia, PCV13 and PCV23. Make sure that you have 2 of them. All right. Very good. These are the 2 most important. Yes, ma'am.
What about shingles?
Yes, that's a very good question. He said no. Just because you just like to say no to her, or there's a basis?
Isn't that a live virus?
Excellent. So he goes back to your point.
I'm sorry, I should have phrased that different. Todd, my nephew's having a transplant in 3 weeks. Should he have the shingles or pneumonia vaccine?
So anybody should be up to date on their live vaccines before we come to transplantation. Okay? But once you get transplanted, we cannot have a live vaccine. All right? Yes, sir.
I want to, when I got mine, I couldn't get a flu shot for a whole year.
Yeah.
But after that, I started getting my flu shot.
Yeah.
After the transplant, I couldn't get a flu shot for a whole year.
So nowadays we changed that. 3 months. Just 3 months. Sometimes even we just give it in the hospital.
Okay.
So 3 months, yes.
Is what you're saying about vaccines the same for people no matter what type of transplant? Because we
Yes.
have heart recipients in
Yes.
here, we have livers.
Yes, that's when it is special to the kidney. I would say it's special to the kidney. But in general, my talk is trying to be as inclusive as possible. So, no live vaccines, be up to date on your disease on this, other vaccination. The most important, flu and pneumonia. But there are a couple of other points here I would like to pinpoint. There are some people that already had transplant long time ago, and they had their spleen out. Or if they have been involved in a car accident and they had their spleen out. These people need to be up to date on other vaccines, right? And this is not being addressed very well. And please, I want anybody that had his spleen out or for a car accident or because of transplant to make sure that they are up to date on 3 more vaccines. It's known as the meningococcal vaccine, the Haemophilus influenza type B vaccine, and then they can sometimes have the hepatitis B vaccine. But the 2 most important, meningococcal vaccine, influenza type B vaccine, on top of the flu, on top of the pneumonia and the pneumonia 13 vaccine. Why that's important? These infections are fighted by the spleen. When the spleen is out, these people are more susceptible to have those kind of infections. Right? Yes?
What about a family member that gets a live vaccine? Are transplant recipients at risk?
She's on a mission to make my life miserable.
Uh-oh.
So, I was knowing that this is going to hit me. It's trying to hide from me. That's an excellent question, and we see it every day. That my recommendation is that we should stay away from those. But I will discuss it with my physician on a case by case because it depends upon the live vaccine. For example, if you take the live polio vaccine that gets shedded in the stool, it can be infective up to 3 weeks. So we need to know what kind of vaccine, how can it be shedded from the body, and what we call it the incubation period, how long that can be infected, so we can be staying away. Very hard, because I have taken care of young families, and you know, he has to change diapers for the baby. And that gentleman, he was dancing in my room. He has a doctor order, stay away for 2 weeks. And the wife, you can see the smoke out of the wife. So, but that is absolutely true. That's a very valid point. So let us summarize what's going on with vaccination. Number 1, what? No what? No live vaccine. You are not going to get live vaccines, and you have to talk to your doctor about how to minimize any risk of getting infected when the loved one next to you is getting a live vaccine. What is the most common live vaccine people are getting these days? The shingles vaccine. Yeah. But if you have young children, you can have a lot of other live vaccines. That's the second one. The third one is that we are going to get the pneumonia shot, and that's 2 types, and we're going to get the flu shot. In the last one, if you have your spleen out, make sure that your doctor have addressed what are the vaccines that you need to have. Give me a reference after I leave this lecture. Where can I see all of that? The CDC website has an excellent table every year. If you just Google CDC vaccination, Center of Disease Control, you will find this table, and they talk about each and every vaccine. You are in charge of your health, okay? You advocate for your life, okay? And vaccines is very simple, very effective way of decreasing the incidence of infections, right? Number 8. Okay.
Dr. Saad,
Yes, sir.
I just want to say this. After I got my kidney, everything you mentioned, the coordinator, before I even come out of the hospital, from the pharmacy to the coordinator I had to go through the classes of understanding what around children. All of these things were taught to me, how to stay away from getting germs from other people, because this would be very effective to you, and with your meds and things. This was explained by the coordinator with your flu shots, your pneumonia shots. All of these things are explained to you from the coordinator. Now, have they stopped this? Because once after you get your transplant, they are right there to tell you.
I agree, but again, you still have to advocate for yourself, but you have a very valid point. All right.
Okay.
Number 8. A good heart is a good kidney, and vice versa. So let's talk about the heart a little bit. We get a kidney transplant. This is a little bit for the kidney transplant, but I believe it can apply for other organs in general. If we look at the kidney transplant, what caused us to lose the kidney? We lose the kidney from 2 major reasons. 40% because they have what we call it chronic rejection, and 40% the person died with the kidney that was functional. If that is a waste of resources or not. Our goal is that when you live, you exceed the life of your organ. If the person go to the grave and the kidney is still functioning, one of 2 things we hope for. We hope for that this person lived so long, okay, you can ask for more, or that they died because of something that we cannot predict. But it's really a shame when a person gets a transplant and then 2 or 3 years, where is whoever is that person is, I'm sorry, he died or she died. 40% of patients will lose their kidney because they died and the kidney was still working. So let us look at these. 30% of those died because of the heart problem. That is my point here. Heart problems plays a major role in getting us to lose loved one, and with them we lose the kidney. I wish my patient can ask me, what should I do to be alive and keep this kidney going? And we really should focus on the heart. So, have to ask yourself, am I at increased risk of heart problem like the person next to me, more or less? So, very simple thing you ask yourself. If you had previous heart problems, heart attack, stent placement, 5 times more likely for a heart disease. If you have one, more likely to have another one. If you have diabetes, if you smoke or smoked, obesity. Do you know how we define obesity? A body mass index above 25. My gosh, that is, it's almost history now. So we really have to look into that. Or if that person had rejection before, or had been on dialysis just for more than 1 year. And actually, there are more literature to say just after 6 months. Look at these. If you have this risk, you are at a higher instance of heart attacks or heart problems or dying with heart problems than somebody that had not have any of that. We don't see people getting off dialysis very quickly. Just the average waiting time for a kidney transplant at our hospital last year was 6 years. So that's a huge problem. Diabetes or heart problems in transplant patients is so huge. Number 1 for kidney failure is what? Diabetes. So we are at increased risk. Our fault, but this is the reality we are dealing with. And my point is that you have to ask yourself, what is my portfolio? How am I in comparison to somebody else when it comes to my risk for having problem with my heart and I have a transplant in place? If you have heart problem before, diabetes, smoke, being on dialysis, obese, had rejection, then you have to ask your doc, you know what, I know that my heart problems are higher than somebody else. What can or should I do? And we don't get that question that often. Number 7. So we talked about the gift. We talked about the vaccination. We talked about the heart. And then the next one, cancer. The cancer in transplant, I will divide it into 2 major categories. And that almost apply for anybody, no matter what is the kind of cancer, because it has to do with that immunosuppression that we are getting. Any idea, if I have to divide them into 2 categories, what is the major things that we tell every kidney patient here? Once a year, you have to go and do it. Skin. Yeah, we definitely do the urology too, but we definitely do the skin. So skin, my point is that one of the things that you need to take out of here, skin by itself is a huge one category, and the rest of the other cancers is a huge other category. The premise in the past, you know what? It depends upon the race of the person. If they are Caucasian, they're at a higher risk for skin cancer. If he's a dark-skinned person, black person, brown person, less likely. But I still believe strongly that everybody should have skin exam once a year, right? Why is that? Look at the data. Here is somebody that does not have any skin cancer. And this is the age match for those that are having skin cancer or in comparison to any other cancer when it comes to transplantation. Look at the huge difference when it comes to comparison to the general population. Huge, huge difference. Look at the skin cancer in comparison to that one person that does not have any form of transplantation. My point, we ignore that. We may be very good in the very beginning. Yes, I just got a transplant. I should be doing everything by the book. But 3, 4, 5 years later, we start forgetting about it. Sleep, skin cancer is a major problem in transplant patients. We do it ourselves, unfortunately, by giving the patient those immunosuppression. You need to go and get skin exam once a year. Yes?
That's the dermatologist.
That's correct. So if there is anything else you can do, which definitely one of them, sunscreen. A second one, avoid sun exposure. I'm sure that somebody would be must kidding me or in Wisconsin telling me avoid sun exposure. But no, yes. Okay? The message, when it comes to cancer, the one should come to the top of your head, skin cancer. Then the second one, all other cancers. So what about the all other cancers? This all has to do with the immunosuppression. But what is interesting here, the general concept about cancer in transplant patients, there are certain cancers that will increase and the majority will not. So we will see a little bit of increased incidence of cancer of the colon, of the breast, but not that drastic. What we really see is 2 major categories. Blood malignancy, lymphoma, leukemia, that is one. The second one that is close to the skin cancers, Kaposi sarcoma, skin cancer, melanoma. This is the second group of cancers. So skin cancers is one, blood cancers is the second one. The third one that is mainly for the kidney people, but also, mainly for the kidney people. This one, you see this one? Kidney. What kidney you are talking about? We are talking about the kidney that had been there and is not doing the job. So that your old kidney, what we call it the native kidneys, they can develop a cyst, and that cyst can become cancer. So the recommendation, if that person has been on dialysis for 5 years or more, should have an ultrasound of the native kidneys, and then every 5 years or more frequent, depends upon whether there is a cyst in the kidney and the kidney has shrunk or not. So it is very interesting for the patient that I ordered this ultrasound on them, and they say to me, oh, but aren't they not working anymore? Why you are getting that ultrasound? And boy, there are some patients that are tough, and they think that I'm just doing it to make money. No, trust me not. So if we don't have trust together, we will have a problem here. I do the best for you. So one of the messages for any transplant kidney patients, if you have been on dialysis for 5 years, you have to ask yourself, did I have an ultrasound of my native kidneys or not? Or if you have been transplanted for 5 years, have I had an ultrasound of my native kidneys or not? And then we'll decide how often we need to do it. I can tell you that at least once or twice a year, I catch a cancer, and unfortunately, I lost a couple of patients in the last 2 years because of that problem. So it is a real problem. Yes?
Our family has polycystic kidneys.
Hmm.
You probably remember that.
Yes.
But, what is that? Do you now, and when I had mine transplant, you did not remove the native kidneys, which were huge, full of cysts. Now do you remove those, or
So
would there be a greater chance of cancer because we already have the cysts?
Yeah, so that is one of the very interesting things. Off topic here, one of the interesting things about the polycystic, that is one of the rarest that they will develop the cancer. Yeah, but the cyst will keep growing. So we will remove the kidney only if they are causing problem. The polycystic is very hard to know whether there is cancer or not because of those cysts. So you have to go out and do an MRI rather than an ultrasound. But again, please, I am here to talk in general, not to provide advice medically, and I will refer you to your doctor. Am I your doctor? I'm not.
We were at one time.
Yes, exactly. Yes. So please.
Or you came in for somebody else, I don't remember.
Thank God, because I was such questioning. The face sound, it looks very familiar. It would be a shame for me if she turns to be my patient and I don't know that. So, so please discuss it with your physician. But in general, polycystic do not have that higher incidence of the cancer, and it's very difficult to screen, and we don't remove them unless they cause symptoms because they are contributing some kidney function. All right. So before we move to the next step, what did we get out of the cancer? Skin, that's one.
Right.
And the second one, blood malignancy, is the most common. And for those that are already being kidney transplant patients, talk to your doctor, do I need to do something about my native kidneys?
Dermatology.
Excellent. And that's dermatology every year. All right? Number 6. Hey, we are almost halfway through. Oh boy, now talk to me about smoking. You are getting me to smoke. Yeah. But smoking, really a problem. We can find that about 30% of patients in kidney transplant are smoking, and 90% of them, after they get the kidney transplant, they will continue to smoke. And that's a problem. Why? Because smoking can get you to lose your kidney or lose your life, as well as get cancer. Really bad, especially with the kidney cancer, especially with the lung cancer. Those drugs that we give to the patients are not a joke. That's why they are labeled by FDA. They should only be prescribed by a person that knows what he is or she is doing. They are really, really very strong stuff that can manipulate your immune system, that can fight cancer. So don't add to the mix by smoking. Smoking will get the patient to die, will get the patient to lose their kidney, or lose whatever organ they are transplanting. Imagine a heart transplant patient and still smoking next day. Or that person will also develop cancer horrendous. And sadly enough, I have lost patients for lung cancer that went like crazy in smokers. So please, if you smoke, stop. If you don't smoke, don't stop. And I don't care whether it is, tobacco or what is it, that's electronic business, nothing. Okay? So, you're talking to me because you don't smoke, so it's easy for you to say that. But it's very hard, I agree. So there are a couple of wonderful websites. There is one that is for those that are fancy with the webs and the apps and stuff like that. That is your tax money, at least being spent on something good. So it's known as smokefree.gov. It's very, very neat site. You click it, take you through steps, which step to do, what step to do, and which medicine to take. And there is another one that has a lot of information known as betobaccofree.gov. This one is very slick, for the app people. This one for the dinosaurs like me, that like to look at data and stuff like that. So anyway, good way of spending tax money. Look at them, smokefree.gov or betobaccofree.gov. Yes?
Is secondary smoke just as bad for transplant recipients?
Absolutely, absolutely. We don't have a lot of that in transplantation, but if it is bad in the primary, I'm sure it is bad in the secondary. All right? Yes, sir.
I just want to say this. I learned one thing. A lot of us might, it takes willpower to do anything.
Yeah.
And when you are around, if you never seen a person with the traits, when you can't breathe or climbing stairs and things, this is devastating just to see. And once you can see this,
I agree. Whatever it takes to scare you and don't go to smoke, I'm fine with that. All right. We are halfway through. Number 5. Blood pressure. That's almost like water, I get a patient literally yesterday in my office, and I asked the patient, how's your blood pressure? Oh, it's okay. I said, what do you mean it's okay? It's like what is here? I said, what's here is very high, 150 over 90. Oh yeah, it's the same way at home. How long that has been going on? For 6 months. Why you didn't call me? Because I feel fine. What is hypertension is? The silent killer. Thank you. So please, if you don't advocate for yourself, others may not be very motivated to work with you. Or say, okay, blood pressure is high in the office. Why is it high in the office? Oh, you know what? I went to your old clinic. It was on the 4th floor, and I walked to your CFAC building. And by the way, you are becoming a very busy hospital.
Keep going.
All right. You are a very busy hospital. So I got stressed. So I cannot, and I don't find a good parking place. And it's getting crazy around, parking here. And it is Milwaukee. And look at the structures. And you have only 2 seasons here. Either the winter and the snow blowing or the construction. Okay. You know what, sir? You caused my blood pressure to go up. So please, we need to take care of this blood pressure business. I will show you how many patients are having high blood pressure after transplantation. When we give a kidney, give or take, the kidney function is about 30 to 60%. Look at those. Look at this study. There is 87% of those patients already having high blood pressure. Diabetes and high blood pressure is very, very, very common after transplantation. So we have to do something. And on average, they are on 2 blood pressure medicine. So don't tell me that, oh, I'm taking too many pills, leave me alone. No, just by having high blood pressure, on average, that person will be on 2 blood pressure medicine. So please, 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 we need to do something about this. But why? Because that person can lose the kidney, whether their systolic blood pressure is high, the upper number, or the diastolic blood pressure is high. The rate goes very quickly, very steep, as the blood pressure goes up. So how to treat blood pressure? Today's talk is not about which medicine to choose. Which medicine to choose is up to your discussion with your doctor. But I will just touch base on the lifestyle. And I am a very big fan of that. Low salt diet. You have no idea how much our food is loaded with salt. And I'm sure I keep the confidentiality of my patients. I will not say who is here that is my patient, who is not. But those that are my patients are sick, tired of me every time. Oh, here is there somebody shaking their heads. I am trying to conceal your confidentiality. Don't. But patients get sick, tired of how I say to them, low salt diet. Our food is so loaded with salt. What is the cheapest seasoning you can ever have? Salt. 2 pounds for 50 cents. So, by the way, just telling you that I am like you. I was in the store and I was walking in the store and then I find that slab of Himalayan salt. Have you ever heard about that? Oh, ladies, yeah, I'm just a guy. Yeah. So I was shocked. 26 bucks for a slab of Himalayan salt. What is that? You must be crazy just to buy something causing you hypertension. I don't care where it's coming from. But salt is a huge thing. That's one. The second one is exercise. We became glued to our chairs, including myself. Whenever you can walk. Whenever you can take the stairs instead of taking the elevator, please do. So low salt diet, regular exercise, weight loss make a huge difference. These 3 are really essential for blood pressure control. And after that, take your medicine after discussion with your doctor. Other stuff, smoking. Make sure that you don't smoke. Larry, yes, please, sir.
What about sea salt?
I don't care.
Okay. I'm just asking.
If the Himalayan is bad, the salt from the sea is bad.
What's the salt substitute?
That is, okay, that's a very good question. That is very dangerous because what caused the salt substitute, the taste, they put a lot of potassium there. And remember, we have kidney issues, so that our potassium can go up. I don't have any interest in Miss Dash, but that is the only thing that is good as a seasoning. It's very expensive if you look at people's budget, but seasoning, you know what? Do whatever you like with seasoning, I hardly go to the kitchen, but please, use your imagination to get things to taste good for you. But salt substitute, the sea salt, the Himalayan salt, all are bad. All right? Sodium, that's basically, at the end of the day, it is sodium chloride. And the seasoning is a potassium. The potassium is bad because it can increase your potassium. You don't want to hate me by getting a call and say, hey, take that lovely cake, select. All right? Wow, we are very close. Number 4. I love to just put anemia by itself because it is a very, very huge problem in transplant patients in general, hypertension in general, vaccination in general. So why anemia is a major topic for me to talk about, and I wish my patients say, you know what, my hemoglobin is low. Doc, let us have a sit down here and talk about why my hemoglobin is low. Because if you are having anemia, you will feel tired, you will feel weak, your heart will work harder. So why anemia in transplant? There are so many reasons, and you should have a very dedicated physician that's willing today to make sure that we address what we can address. Why do you have anemia? Most commonly, iron deficiency. We are the vampires in suits. I send you to blood work 3 times a week after transplantation. We are sucking blood day and night. We can definitely cause patients to have iron deficiency. So that's one. For young women, they lose it with their periods. They come from dialysis, they're already having iron deficiency. Second, drugs. All the drugs we give to the patients can cause anemia. Sirolimus, everolimus, Prograf, cyclosporin, Celsep, Imuran, you name it. So they can cause anemia. Third, anemia can be manifestation of infection. CMV infection, BK infection, and there is one very notorious, is known as the parvovirus. Actually, you diagnose that parvovirus by seeing very significant anemia. Also, God forbid, if the patient has cancers, certain cancer can cause us to have anemia, or if there is inflammation in the body, like somebody with some infection that we haven't found out, can cause us to have anemia. Patient that goes through rejection, that part of that inflammation can cause anemia. But if I have to pick and choose, I would say the iron deficiency is a major one, the drugs is a major one, infection is a major one, and this one, when the kidney function is not good, and what is not good, less than 60%, there is a hormone secreted by the kidney known as erythropoietin, Froedtert, is not enough, and that can get us to have anemia. So that's why we send the patients to get those injections. Your doctor responsibility is to find out why and then direct you in the right direction. The most common, iron, appropriate drugs, and infection. Please make sure that your hemoglobin level is stable and is not trending down. And then you have a discussion about why my hemoglobin is down. And then if you have the adequate explanation, then you can live with it. Number 3. That's 3 to go. This one we're going to stop at, and I probably spend like 10 minutes. You get a transplant, and you have been through a lot. But I think during the process, you get bonded to us. The one that care about you is us. The one that gets the call to you, that's us. The coordinators, you have a pre, you have a post coordinator. And if anything happens to you, call us. And then you forget about anybody else. So you forget about that you had a primary care physician. You forget about that you had a kidney physician before, or a heart physician before, or a liver physician before. And once at a sudden, it almost, you start thinking, or start giving you the impression, who became your primary care physician. That is the biggest mistake you can do to yourself. I think by doing that, you will not get the best care. You know, these transplant people are focused about transplant. For me, the first thing that I look at is that kidney. Is the kidney working well or not? And if it's working well, okay, I can take a breath. But my gosh, you are a human being. So please, let us establish something here. We are a triad. A transplant patient, you are in the center, and we work together between the transplant center and your primary care. You can remove that local nephrologist, become the local cardiologist, become the local hepatologist, become the local pulmonologist, whoever. But the relationship is you go back and forth, and as you get more out of your transplant, you belong more here and less here. Okay? Why is that? because you will have a better response and more probably primary care response. Yet, does that mean you shouldn't be calling me or you shouldn't be calling your center? Or when should I call you and when should I call my primary care? Or what is the role of my primary care? If you have persistent nausea, vomiting, or diarrhea, call us. It's too late for the primary care to intervene. Why? Because your kidney will get dehydrated and we will be in trouble. We like to say that. So if you wake up today and you went to a restaurant last night and you have a nausea and vomiting, call your primary care. Most likely, unfortunately, you have a food poisoning. But if you have a diarrhea and nausea for a week, we have a problem here. Call us. Let us save that order. If you have bleeding means something is wrong. We need to know because blood transfusion needs to be done or not done, and we need to figure out why you have the bleed. If the liver function test goes out of control, we put you on a medicine can cause your liver function to go out of control. Call us. If the blood pressure is becoming out of control, your primary care will put you in one medicine, two medicine. But if you need 3 and 4, or we figure out why your blood pressure is high, please call us. If your blood count is not going well, blood count too little, too high, or if you have bumps and lumps that can tell us that there may be cancer, God forbid, the infection in the brain, pneumonia that's not going away, if you are going to go for any surgery, you need to call us. Because some of the medicine that you are on may not get you to heal well. If anybody is in a medicine known as sirolimus or everolimus, that medicine may need to be switched in 4 or 6 weeks ahead of surgery. So please, before surgery, or if you went to surgery, call us immediately after surgery. For example, God forbid, if you are in a car accident, you went to the OR, please, next day, let us know so we can help the person that's managing you about your immunosuppression. If you have a fever that is persistent fever, you are next to somebody that was sniffling and having a little bit of a high fever tonight, probably tomorrow you will catch the same cold from him. I cannot do too much about it. But if you have a fever for a week, 2 weeks, 3 weeks, there's a problem there. If you have been in the hospital, any time in the hospital, just let us know that you were in the hospital. Just like to review your records, make sure that they are okay. Definitely, I don't want you to come out of here okay. I have X or Z amount illness. Since it is not on the list, I'm not calling the transplant center. If you are in doubt, call us and then we'll deal with it. But it's better to be safe than sorry. But please, you really need to continue to establish your relationship with your primary care. What your primary care physician is good for? Diabetes. They can manage diabetes. Absolutely. It's like anything else. Diabetes and transplant, like diabetes and no transplant. There are some medicine we worry about them, but overall, primary care can manage your diabetes. They can treat your cholesterol. They can treat your high blood pressure. Tobacco abuse, we talked about it. Cancer screening, we talked about it. If there is an infection, UTI, pneumonia, they can deal with it. So please, make sure that you have a good relationship with your primary care. I see my patients after the 3rd year, once a year. These 12 months, I just see my patients in cyberspace. You need to see your primary care physician. So these are issues that primary care can handle. But there are 2 or 3 other issues that primary care can handle very well. Uric acid. Many of the medicine we give the patient will cause the uric acid to go up. That's one of those that will eventually cause something known as gout. And primary care can handle that. Put the patient on allopurinol, they will be fine, except for those that are on a medicine known as Imurant. Then we need to adjust those medicines. But in general, primary care can handle uric acid very well. Primary care can handle also this issue. Mental issue. And that is another issue I wish my patient would ask more about it. I think we still have the stigma about, I'm depressed or I have an anxiety or not I'm feeling well. that you don't come forward and share it with your either primary care physician or transplant physician. We have a lot of resources, and you deserve the best for your treatment. That is one thing I wish my patients share with me when they are not feeling well mentally. There's nothing more easier than sending them to our psychologist or our psychiatrist if need be. But if I don't know about it, I wouldn't be able to offer help. And the next one will be this one, sexual function. And it's amazing how open a society we are, yet when it comes to that issue, we still, you go to the doc, that is not an issue that's been well addressed, or people will brush it off. I can share with you one story. I don't know whether it's funny or sad, but I will just share with you. One of my patients had kidney transplant, and see him with his wife, they come to me. I know that patient very well for years, till he got his transplantation. And after a year, he came to me alone. And I said, oh, where is she? We are separated. I said, why? Oh, we just separated. I said, okay, next time, I'm sorry to hear that. Hopefully things will work out. Next time he came to me, said, you mean, you know what? We are divorced. I said, why? He said, you know what, doc? I will tell you. I got this kidney transplant, and my sexual life changed upside down. I had no desire, have nothing, and after transplantation, my wife was used to certain lifestyle for years before transplant, and now she cannot handle me, so she divorced me. That's very sad. That is really, yeah, that's true, but very, very sad. And if this gentleman would have, shared with us, I think we have a psychologist, we have somebody that could have mended this relationship. She was used to certain lifestyle for years. She was happy with that. But now he was not happy. He was pushing and stuff like that, and we ended with a divorce. I think that's the extreme. Most of the time we see that there is lack of desire even after transplantation. Becomes very frustrating for people. We have a very good urology department as well as urogynecology department. So if you don't share, we will probably not refer to those. The more important and the one that scares me so much are the young folks, that 18 to 50. And I get so nervous because either they don't have a safe contraception in place or they push to get pregnant. And that is, very hard to handle. I handled quite few of those that get pregnant, but that's put a lot of stress on these kidneys. So we really need to make sure, if we are going to get pregnant, to understand the risk and how we are going to handle it. And you should be followed in a place that is really comfortable with handling pregnancy. Another one that people don't feel comfortable handling for transplantation, and you really have to have a good physician, is bone. You don't have any fracture, you are going on with your life. Look at how much bone is lost, whether it is female or it's a male or all of them, within 6 months of transplantation. Significant bone loss happens with transplantation. We put patient on steroid, we put the patient on program, so make sure, doc, am I having my vitamin D checked, my calcium is okay or not, and did I have a bone density every other year or not? Should have one immediately after transplantation and every other year. And do I need to worry about my bone loss or not? Please, please, please. Yes, sir.
I come to find out what prednisone do for, it gives you off the paralysis.
Actually, give you what?
It gives you
Osteoporosis. Yes.
Osteoporosis.
Yes.
Prednisone.
Yes.
Yeah. And as you go along taking prednisone, you will get the loss of your bone. Or am I saying it right?
No, sir, you are saying absolutely right. It is one of the reasons for us to lose bone. But I don't want people to leave this room and say, hey, Saad said prednisone is causing osteoporosis. Guess what? I'm not going to use my prednisone. And then I get all phone calls tomorrow. What did you say last night? it is one of the things, that's why it is important to sit down with your doctor and say, okay, I am losing my bone. Why is that? What can we do about it? The whole point to bring the issue up with your doctor. What's my primary care? What's my diabetes is? What my blood pressure is? Why I'm using every medicine? Why do I have anemia? And what's about my bone disease? And then I'm a little bit anxious. What can I do about that? And then let's talk about my privacy, private life, my sexual life. What can we do about it? Okay? Obesity, we gain weight, absolutely, especially after transplantation, especially with those that are on prednisone. Not only that, but ask any single transplant patient, and they will say, you know what, I couldn't believe how my appetite is way much better after transplant, especially after things settle down in comparison before transplantation. So we gain weight after transplantation, and we have to do something about it. We actually started having a very good bariatric program, weight reduction program by surgery. You will not know about it unless you talk to your physician and he feels comfortable that that is the only solution. But we have dietitians, we have programs, we have support, and really, really, obesity can make our lives miserable, especially when it comes to diabetes and high blood pressure. The final one that I like to talk about is that infections, especially after we are out of transplant for a while, we will get infections like anybody else. Pneumonia and UTI is very common. Don't want you to panic just because you had a pneumonia or you had a UTI after transplant. You will get one every now and then. But the one that's more serious that you talk to us about it when it is a fungus, when it is a virus. But other than that, like anybody else, your primary care can treat your UTI, can treat your pneumonia. So, yes, sir.
My question came over the online viewers. The hard question is, what do you do when your primary care physician is out of network? Is there something you can do as a transplant to make that work?
Yeah, so if he waits for me on the next slide, I will answer that. It is on slide number 2. Okay, so, yes, sir.
Repeat that question, because I don't know that the mic would have.
Sure. So the question, if that a heart transplant patient or any other patient, that the transplant center belongs to one insurance carrier. On the other hand, his primary care or her primary care is out of network. Now what to do? How the transplant center can help there? So I will answer that in the second question, the next slide. So far, we are almost done, and I'm so happy that you are still awake, alert, attentive. So let's just summarize. We talked about how it is a gift for us to have a transplant. We talked about the vaccination and no live vaccine. We talked about a lot of other stuff like cancer screen, and the major one is a skin cancer. We talked about the heavy heart, heavy kidney. We talked about anemia management. We talked about the role of your primary care physician and how it is important to bond with your primary care physician. We talked about smoking and how it is very essential to quit smoking and what are the websites for that. All these questions I wish my patients can address with me, all right? Now, number 2, again, this applies to anybody and everybody, and hopefully will answer that question that was brought up on the web as well. So far, I'm getting close to the end. Are you following me? Is my message getting there? Okay? All right, great. Help wanted. It's very general. That is exactly that web question. If I have that question, whatever is that question is, can I have some help? Yesterday, there is a patient that came to my office and I was going to see her. And my nurse stopped me, said to me, you know what, She said, no, you are not going to see her. So my first reaction was, please, if she doesn't want to see me, why did she show up to the clinic? She said, no. She likes to see you, but on a condition. I said, what is the condition? She cannot pay more than X amount of money. Okay? And if your visit is going to cause her, say, $200, she's not willing to see you. I said, but I am as clueless and at loss like she is. I have no idea how to address that. Why we ask for help? And that's what it is. Why it is important to ask for help and to address these issues, whether it is money issue, whether there is no physician, because all of that will lead to what? Non-adherence. You will not stick with your treatment. No matter how good I am as a physician, or what's a wonderful plan as I'm going to write for you, if you cannot be adherent to that, you will not follow and you will lose your organ. So what are the red flags for a person that's not going to be adherent to medications? Young folks, less than age 25. I get a lot of patients from the children's hospital, and it's very sad. 50% of them will lose their kidney when they transition to adults. Males, always males are non-responsible people. Girls, God bless their hearts. Non-Caucasians, that unfortunately has to do with the socioeconomics and how being disadvantaged. Definitely in non-US resident, because of limited resources, we cannot say to a person, we will not transplant you because you are not a US citizen. We go through a certain other process, but definitely even if you transplant them, they don't have the resource to keep the organ in place. But this is the major one. Look at the rest. Poor social support, illness inside, poor perceived treatment benefit, psychological or psychiatric disturbance, poor provider-patient rapport, complex medical regime, lacks of health coverage. All of these, frankly, you put me in front of a patient with all of these, and I will just sit down and cry because I don't know. I have not been taught how to deal with that. There should be help there. So who is that help to answer this? All of these. This is a wonderful lady. I don't know how many of you comes to Froedtert and knows Jenny. Jenny is one of our social workers. What I'm referring to, there is a wonderful, we are a team, and it is the social workers that are really helpful to answer all of those questions. So I was sitting next to Jenny last night, and she said to me, you know what, your voice sounds a little bit congested, you look tired, what's going on? I said, you know what, on top of that, I have to prepare a lecture, and I haven't started yet. And she said to me, use previous slides. She said, they made it more miserable for me. They gave me a title, so I have nothing. So she said to me, you know what, I will help you. Said, you know what, great. So she gave me the idea for number 2. So that is, I owe it to her. She said to me, don't mention me. I said, no, I'm going to mention you. I'll give you credit. So that's what social worker, she said. If finance or health becomes a barrier for care or medications, please do that. Provider may be able to reduce the number of tests. I order a lot of tests, but it comes to me and say, please, we really need to tell me the essential. I will do my best to do the essential until the insurance is resolved. Many patients are on brand names and they don't know that the generic is as good as the brand names. Let us switch it to generics. Or let us look into insurance options. Let us talk about fundraising. Let us talk about resources. And she said to me, we cannot help to improve the situation if we don't know what is happening financially. So my answer for that person that raised that question on the web, please go to your social worker at the hospital and say to them, here is a situation, what are my options? She gave me another lovely slide, is that you really need a support person. And I agree with that 100%. You come to the visit and you get bombarded by a lot of information. You're just coming from surgery or you're coming from an illness, and sometimes you just hear what you want to hear. It's way much. It is amazing if you have somebody that is just coming, sitting next to you, and that person is not under the stress of transplant. He's just an advocate for you. And you go home, and hey, by the way, Joe, did you hear that the doctor said that? Are you sure? They said that. Oh yeah, they said that. And what about your blood pressure medicine? Oh, the Himalayan salt was good. No, come on. It's that kind of. You really need that sound voice. You need a support person. So please, when you come to your visits, we are a society that believes strongly for being independent, mature, making decisions for ourselves, tough it out, keep it inside, keep going, all that kind of stuff. But you know what? We're human beings. And we are not taking away your freedom. We are not taking somebody to make a decision for you. We just need somebody that is not under any of that stress to just be a sound mind for you, to hear the same message that you do. So I wish my patient would include a support person in their care. I agree. I mean, every visit, it is important to implement their feedback from their perspective. You know what? No, he's not the same at home. How many times a wife will come and say, you know what, because became snappy. And the reason, they are on high dose of steroid, all right? Or I have to lock the fridge because he just wake up at night time and he is eat and say in the morning my sugar is 400. All that kind of crazy stuff. Some patients don't realize their symptoms. They really need a support person. They will help them through their journey. And there is an amazing program at Froedtert Hospital. We developed a program known as the Peer Mentor Program. Those that have been through a transplant can advocate for those that have not been, or they have been with a different journey. Yes, Larry. Oh, he's one. Yeah, here we go.
I went to peer mentor program.
So here is a live example. I think we have about 30 of them now. So we can hook you up with somebody that just, bounce things with you if you want to. I think we covered a lot of ground, and I hope I answered that person's question that was raised on the web. We covered why is it gift, what about vaccination, what about cancer, what about high blood pressure, what about anemia, what is the role of my primary care, what about smoking, what about if I need help, where to look for help. If there is any other questions that is burning in your mind, or would I stop here? Yes?
In the beginning, you were talking about living donors, and it's really a pre-transplant issue.
Yes.
But you did bring it up, and the statistics show that a living donor is much preferred.
There is no question. I agree.
Okay. So in my personal experience in working through this with Froedtert, I'm surprised at the amount of time that transpires between finding a living donor that gets through the, what we call packet,
Yeah.
and then comes in for a day-long, basically, review.
Yeah.
That once they hear that they're going to be scheduled, it's 6 weeks out. And for me, in my experience, I've had that happen 3 times with delays in between. And so when I feel that, or have that happen, and then I see the slide that says, you probably don't want to be on dialysis more than a year, maybe even only 6 months, I get anxious. So I'm just frustrated and questioning, why does it take so long to qualify living donors?
That's a very valid question. So first one, please accept my apology on this, on behalf of the program, if the process is long. We are trying very hard to improve the process. That's one. Second one, there are 2 people lives at stake here. When it comes to deceased donor, there is only, there is a deceased one that already donated and is dead. But there is only that recipient. But when it comes to living donation, there are 2, the recipient and the donor, correct? And the donor, our commitment to the donor is that you cannot do any harm, or you try your best not to do harm. And that means a lot of testing beyond the scene. All right, that's one. They go and talk to a psychologist, they talk about physical exam, they talk about labs, they talk about imaging, and we cannot even break confidentiality. So sometimes when the donor is not ready, okay, but has been saying, you know what, I'm just doing it because X and Z told me that I have to do it, okay, but in reality, I don't. We have to find a way for that person that you will never know that your loved one came forward but they were not ready for. Not all programs are created equal. And we are, I admit, somewhat conservative program, and we are obsessive, and we try very hard to make sure that we have done our best to protect the donor health and life. There are some people in this room who already have living donation, and we put their donors through a lot of testing, and they were frustrated with us. And I can tell you that when they look back, they hugged me and they thanked me, and they felt that it was worth it. So I apologize if the process looks a lot longer for you, but I can tell you that we are working so hard to make sure that we do the right thing. I strongly believe that we are trying our best to do the right thing. Each and every case, at the end of the day, comes in front of me, and I look at the file from A to Z. I will be leaving here, and there are 2 cases sitting on my desk. I will not go home tonight till I see, look at them. I'm here, it's 8, should be home after this. I will go home, I will go to my office, because there are 2 cases I have to make a decision. Can we do better? Absolutely. That's my job, to every day challenge myself and my team. But if we do a transplant at Froedtert, I like to make sure that if something bad happens at the end of the day, I look back and they say, you know what, I would have done the same thing again and again. It is really out of my hands. Can other places do transplant and have looser selection criteria? You bet. Less of follow-up? You bet. And then we'll let them speak for themselves. So I truly, truly understand your frustration. I would like for you to still work with your coordinator, but the unfortunate thing, even if I know why the reason, I cannot share it with you why this is delayed.
And maybe I'm just going to say we've got a lot of folks online, and perhaps if you have a moment.
Yes, I can talk in the side.
You can talk a little bit more, unless it's Merle. Is there anything else for folks online?
No, I have still one question for them.
Okay.
You don't have any other question? Where did we stop? We stop at number 2.
Yeah.
Yeah, so it really doesn't bother you? That was my test for you. Are you really following me or not? Yeah. So there's number 1. Come on.
Is there a number 1?
Yeah.
Let's see.
Drum roll, please.
So,
Drum roll.
So, exactly. And number 1 is this one. Has anyone told you today just how awesome you are? Thank you so much for listening for me, for putting up with me, and I truly, truly appreciate it. Thank you so much.
For those of you